Hello, this is Dr. Raymond Lamb from the University of British Columbia, and it's my pleasure to welcome you to this final presentation in our series on measurement-based care training. In part one, we talked about measurement-based care and reviewed the evidence for its effectiveness in improving outcomes in people treated for depression. In part two, we examined the clinical scales and tools that we recommend for measurement-based care. And in this part three, we'll look at antidepressant treatment algorithms to support measurement-based care in your patients. Again, these are my disclosures and sources of my funding. The objectives for this presentation are to describe the rationale for treatment algorithms, to show a simple algorithm for selecting an antidepressant, and then to look at switching and adjunctive strategies when the first antidepressant isn't working well enough. Again, many of these resources are available at our website, workingwithdepression.psychiatry.ubc.ca. Our MBED project looks at an implementation plan for measurement-based care in Shanghai, China. And we have developed resources for the hospital, for patients to use, and for doctors, including this MBC training program, the scales package that we previously described, and now we're talking about the medication algorithm. Treatment algorithms are either loved or hated by doctors. When we talk about treatment algorithm, we're really talking about an ordered sequence of clinical decisions that helps to solve a clinical problem. And some of the advantages of treatment algorithms include standardizing care and reducing variability in care, that these treatment algorithms can be used alongside measurement-based care because many of the clinical decisions are based on scores from rating scales. But we really want to point out that treatment algorithms are not like a fixed recipe, that certainly you can deviate from the recommendations depending on the clinical situation. So you don't have to follow the algorithms if the patient in front of you has differences that make you select different treatments. These treatment algorithms are particularly helpful for trainees, residents, and junior doctors to illustrate the important factors to consider in clinical decisions. But I know that many of you viewing this presentation now are actually very experienced doctors, psychiatrists, and so you don't really need a treatment algorithm in terms of selecting medications. However, we'd ask that you look at this presentation, see whether you agree with some of our treatment choices and decisions. And in particular, let us know if you feel that this approach is helpful for more junior physicians. The treatment algorithms that we're discussing are based on the Canadian Network for Mood and Anxiety Treatment Depression Guidelines that were published in 2016 in the Canadian Journal of Psychiatry and are available on our website at canmat.org. This really just illustrates the simplified algorithm that we'll be discussing today. And we'll go over each of the components of this algorithm on a step-by-step basis. But the first step is really, how do you select the right antidepressant for your patient? And this isn't really a simple decision, because the CANMAT guidelines have shown that there are many first-line recommended antidepressants. In fact, most of the newer second-generation antidepressants are regarded as first-line because they've demonstrated efficacy and tolerability. The second-line medications are really those that have good evidence for efficacy, but probably have issues relating to side effects, or they may be newer medications without as much experience. And the third line medications really include those that are more difficult, more challenging to use, like monoamine oxidase inhibitors. But how do you choose among the first line antidepressants? Well, we know that in selecting the antidepressant, we have to consider patient factors, medication factors, and previous treatments that the patient may have had. Let's go over these. When we look at patient factors, for example, we need to consider the clinical features, the symptoms that the patient's experiencing, whether they're having any comorbidities in regards to physical conditions, other medical conditions like diabetes, or whether they have other psychiatric comorbidities. We also have to look at the response and side effects that they may have experienced with previous antidepressants. And then we have to consider patient preference in terms of the decision on which antidepressant to use. There are also medication factors that are important to consider because there are differences among the different antidepressants. We'll talk about some small differences in comparative efficacy among the antidepressants. There are small differences in terms of tolerability and the side effect profile to all the different antidepressants. Importantly, we have to consider potential drug-drug interactions when we're selecting a medication, particularly if the patient is on medications for other conditions. Simplicity of use is important, so medications that can be given once a day and that you don't have to worry the time of day or whether you need to take them with food or not. And then for many of our patients, cost and availability are a particular issue. And so we really have to regard that antidepressant selection must be individualized because the relative differences between the medications are small and the differences between patients are large. And so we have to consider both patient and medication factors in selecting a medication. Well, how do we assess differences among antidepressants in efficacy and tolerability? In the CANMAT guidelines, we examine the evidence for superior efficacy based on meta-analyses. And we found that several medications, including escitalopram, mirtazapine, sertraline, and venlafaxine, had good quality evidence, level 1, the highest level, to support some superior efficacy compared to the comparator medications in these meta-analyses. Agomelatine and citalopram had some evidence, not quite as strong, to support their superior efficacy compared to these comparator medications. However, these differences between the medications were quite small. There's only modest superiority for treatment response, about 5 to 6% improved response rates compared to these other medications. However, even a small difference in response could be significant when you consider it from a population perspective. It really means that if you treat 100 patients with one of these medications, you're going to get an extra 5 or 6 people better compared to using these medications. So for that reason, we did feel that there were small differences in efficacy with some antidepressants. In a more recent network meta-analysis comparing 21 antidepressants, it was found that 3 antidepressants had the most favorable profile for both efficacy and acceptability. And these 3 medications were agomelatine, escitalopram, and vortioxetine. So again, based on these network meta-analyses, some support for superior efficacy and tolerability among the different antidepressants. What about other factors that influence antidepressant selection? Well, obviously side effects are important, but the differences in side effect profile among the antidepressants, particularly the second generation antidepressants, are quite small. And it's very clear that doctors have many different opinions about the side effects and whether one medication has more side effects than another. However, we do know that there are differences among the antidepressants in sexual side effects, using scales that specifically assess sexual dysfunction. And so we know that there's a lower risk of sexual side effects with medications like agomelatine, bupropion, desvenlafaxine, mirtazapine, vilazodone, and vortioxetine. Also, in terms of drug-drug interactions, most of the antidepressants don't have clinically significant drug-drug interactions. There's minimal risk with desvenlafaxine, escitalopram, mirtazapine, sertraline, and venlafaxine XR. The antidepressants that you should avoid if you're worried about drug-drug interactions, though, are really fluoxetine and paroxetine, because it's clear that they are potent inhibitors of cytochrome P450 2D6, and that can interact with many medications that are used by patients for other conditions. So to summarize, the antidepressants with the best evidence for efficacy, tolerability, and safety include escitalopram, sertraline, venlafaxine XR, and vortioxetine. And so two SSRIs, an SNRI, and then a novel medication, a multimodal medication among these choices. And so that's why we recommend that in terms of the initial selection of antidepressant, that you consider one of these 4 medications. Let's look at some clinical examples of how to select an antidepressant. In this first scenario, we have a patient with a lot of anxiety. They have anxious worrying alongside some agitation, and as well they have comorbid cardiovascular disease and a family history of bipolar disorder. So even with this limited information, what antidepressant would you select for this patient? Well, we would recommend an SSRI medication like sertraline or escitalopram. And why is that? Well, SNRIs may be slightly more activating than SSRIs, and because this patient is already agitated, we might avoid those. In addition, SNRIs have a slightly higher risk of hypomanic responses, and given the history of bipolar disorder, family history in this patient, you might want to avoid SNRIs as a first choice treatment. In addition, we know that sertraline and escitalopram have demonstrated cardiovascular safety in many studies. And we probably wouldn't use citalopram as our first choice because it's known to have a issue with QTc prolongation. And finally, we'd probably avoid fluoxetine and paroxetine because they have more potential for drug-drug interactions, and this patient is likely on other medications for their cardiovascular disease. Let's look at a second scenario. This time, the patient has a really flat mood. They don't really feel anything. They're not necessarily sad. They just feel flat. They also have prominent cognitive symptoms, including poor concentration and memory, and very low energy. This patient has comorbid panic disorder as well as irritable bowel syndrome. So for this patient, what antidepressant would you select? Well, we would recommend, in this case, an SNRI medication like venlafaxine XR or desvenlafaxine. And why is that? Well, SNRIs, again, tend to be more activating with less risk of emotional blunting compared to SSRIs, so may be more selective for this patient. SNRIs are also slightly better than SSRIs in treating cognitive problems and energy problems. Other SNRIs like duloxetine and bupropion may be good for energy, but there's less evidence for their efficacy in anxiety disorders. And given that this patient has a comorbid panic disorder, it seems like we're better off with other SNRIs. And vortioxetine is good for cognitive problems, but there are higher rates of nausea associated with vortioxetine compared to some of these other medications. And that's why we would stay with venlafaxine XR or desvenlafaxine. So I hope those clinical examples can help illustrate how we would choose the first antidepressant for our patients based on some of these clinical features and the medication factors. So once we've selected our first antidepressant, then we need to optimize the dose over the course of acute treatment, which usually lasts 4 to 12 weeks. And in this case, we need to assess the response that the patient's having, any side effects that they might be experiencing, and then any safety issues that might be affecting the patient. Now, when would you increase the dose of the antidepressant? How long would you wait if they were not getting better? Well, in contrast to previous beliefs that it might take up to 8 weeks for antidepressants to start working, there's ample evidence now for early onset of antidepressants within the first 2 to 4 weeks. Early improvement in symptoms, which we define as more than 20% improvement in the depression score, can actually predict the final symptom response at 6 to 12 weeks. Early improvement in symptoms also predicts the final functional improvement in people with depression. And so we can look at lack of early improvement as a clinically useful predictor of lack of response to antidepressant. So that's why we say that less than 20% improvement in the depression score at that early 2 to 4 week mark indicates that the patient will likely have low probability of final response at 6 to 12 weeks. Let's give an example of how we define early improvement. As we mentioned, improvement we've defined as more than 20% reduction in score from baseline. And so in the example here of a PHQ-9 with a baseline score of 15, early improvement really indicates a change in the PHQ-9 score of 3 points or more from baseline. When we define response, we usually define that as 50% or more reduction in depression scores from baseline. So in this case, this would be a score of 8 or more on the PHQ-9 from baseline. And finally, when we define remission, this is a score in the normal or remission range of the scale, which for the PHQ-9 is a score of 0 to 4. And so just to remember that a clinically significant change of 5 points on the PHQ-9 is clinically significant or clinically relevant, whether that's worsening or improvement in the severity of depression. So this leads to our 20 and 4 rule, which is if there's less than 20% improvement in depression scores in 4 weeks, you should do something. And by do something, we usually mean increasing the dose of the medication, although it might mean adding an adjunctive treatment. Of course, this also depends on factors like severity. If they're more severely depressed, you may not want to wait 4 weeks. You may want to do something, increase the dose at 2 weeks. It also depends on side effects, because if they're experiencing troublesome side effects, you may want to wait a little longer to see if the side effects settle down. It also depends on previous treatment response. Again, they may be someone who has been slower to respond in the past. And also, we should consider whether there might be a stressful life event that is affecting them and leading to less improvement than you'd expect with the antidepressant. So these factors have to be considered, but generally speaking, we would want to increase the dose of the medication within 4 weeks if the patient is not getting better. Once the patient has optimized their dose in this acute treatment period, then it's important to assess whether they are in remission or whether they are not in remission. In our CANMAT guidelines, we note that there are 2 phases to treatment of depression. The first acute phase usually lasts 8 to 12 weeks, and the clinical question is really, how do you get patients well? The goals of this phase are really full remission of symptoms and improvement or restoring functioning in these patients. And you can see here that there are a number of activities that support the acute phase of treatment. Once the patient is in symptom remission, then they go into the maintenance phase. And in the maintenance phase, the primary clinical question is, how do you keep them feeling well? And this phase can last 6 to 24 months or longer. The goals of the maintenance phase are to return to full functioning and quality of life, and then to prevent any recurrence of depressive episode. And again, the activities during the maintenance phase are slightly different in order to optimize functioning in these patients. Once patients are well on an antidepressant, how long would you continue it? Well, it's clear from a lot of evidence that all patients should continue antidepressants for 6 months after they're in remission of symptoms. But of course, many people need longer-term maintenance treatment in order to prevent relapses. And patients with risk factors need at least 2 years of treatment. These risk factors include frequent and recurrent episodes of depression, very severe episodes, for example, if they have psychosis or severe impairment or high suicidality, they need longer maintenance treatment. If they've had a chronic episode of depression, then they need to stay on the antidepressant longer once they're well. Psychiatric or medical comorbidities is another risk factor for relapse, and those patients generally need a longer period of maintenance. And finally, if the depression has been difficult to treat, if it's taken a long time to get them into symptom remission, then they'll need to stay on the medication for a longer period of time. And so again, for many of our patients with these risk factors, we recommend at least 2 years of maintenance treatment. But for some people, they will need to continue on the medication for a lifetime. So when patients are in full remission after acute treatment, we recommend that they maintain their medications for 6 months or longer if they have risk factors. But what if patients are not in remission, if they're not well with acute treatment and the medication has been optimized? Well, then you need to consider side effects that they might be experiencing to the medication, the kind of response that they have to the antidepressant, and then the amount of time and that you have in terms of dealing with their depression. And the importance of this assessment is that then the consideration, the treatment decision, is whether you switch medications or whether you add an adjunctive agent. First, let's consider, when do you switch the antidepressant? Here are the factors that you need to consider for switching to a second antidepressant if the first antidepressant hasn't been effective. You would consider switching if it's the first antidepressant that the patient's tried. If the first antidepressant is poorly tolerated, if they're having a lot of side effects, then it makes sense to switch the antidepressant. If the patient has no response at all, and by that we usually define as less than 25% improvement in the depression score, then you might want to consider switching to a different antidepressant. If you have more time to wait for a response, so let's say the patient is getting another treatment like cognitive behavior therapy, you have a little bit more time, then you might consider switching, because some of the add-on strategies work a little faster than switching to another antidepressant. And finally, you need to consider patient preference. So perhaps the patient prefers to switch to a different antidepressant rather than adding on another medication. So if you decide to switch antidepressants, then all things being equal, we'd recommend that you switch to an antidepressant of a different class. And so you would go back to looking at the initial 4 antidepressants and choose another medication that's in a different class than the first antidepressant. But what about adding on an adjunctive medication? When would you consider doing that instead of switching? Here are the factors to consider for adding on an adjunctive medication rather than switching to a different antidepressant. If the patient's failed a couple of medications, then it's less likely that they're going to respond to a single antidepressant, and so it makes more sense to add on an adjunctive agent. If the antidepressant is well tolerated, then add-on is more likely because it's no use adding a medication if the patient's having side effects to the first antidepressant. You may as well switch that medication. More importantly, if they've had a partial response to the first antidepressant, if they've had more than 25% improvement, then it makes sense to add on rather than switching so that you don't lose the benefit of that first medication. It makes more sense to try to boost the effect of the first antidepressant rather than switching to a different one. Similarly, if you have less time to wait for a response, if the depression is severe, if they're greatly impaired because of the depression, then it makes more sense to add on because sometimes that's a faster response with an add-on strategy rather than switching to another antidepressant. Sometimes the patient prefers to add on a medication for some of the reasons that we've already described. And sometimes we want to target specific residual symptoms or side effects by adding a second medication that may address those specifically. So those are the reasons for adding on an adjunctive agent rather than switching to another medication. In our CANMAC guidelines, these are the adjunctive strategies for people who have had no response or a partial response to their initial antidepressant. And you can see all of the first line recommended treatments are atypical antipsychotics: aripiprazole, quetiapine, and risperidone. And that's because there's a great deal of evidence to support the benefit of adding on one of those atypicals to an antidepressant in order to boost the effect. The second line recommendations include some of the atypical antipsychotics like brexpiprazole that are newer and we don't have as much clinical experience with it, and then olanzapine, which has good evidence to support its efficacy, but because of the metabolic side effects, we have downgraded it to second line. And then there are a number of other second line medications in which you add on a second antidepressant, like bupropion or mirtazapine. And again, good evidence to support that adding on those specific agents, those specific antidepressants, will help the response when you add it to an antidepressant It's just that the evidence isn't as clear as with the atypical antipsychotics. Lithium and triiodothyronine, or T3, are included on this list because there is evidence to support their use as adjunctive agents, but most of that evidence is with the older tricyclic antidepressants, and there's much less evidence for adding on those medications to the second generation antidepressants that are more widely used now. And in the third line recommendations, these have much less evidence to support their use. So for example, stimulant medications have very mixed evidence, a lot of negative studies showing that they're not helpful in improving depression, although they may help with concentration and energy. Similarly, other tricyclic antidepressants, very little evidence to support their add-on to a first antidepressant medication. And then there are medications, newer medications like intravenous ketamine that were considered still experimental medications as of the CANMAT 2016 guidelines. And then medications like Pindolol, which are not recommended because they have not been shown to be helpful as an add-on strategy. This slide shows the dosing recommendations for using atypical antipsychotics as add-on agents to antidepressants. And it's a reminder that we usually use lower doses of these medications as an add-on rather than compared to their use in bipolar disorder or in schizophrenia. And so, for example, aripiprazole, we found that low doses of 2 to 5 milligrams can actually be very helpful when added on to an antidepressant medication. Of course, when we're using atypical antipsychotics, we have to consider the side effect burden of these medications. We have to remember that to look for extrapyramidal side effects like akathisia. Some of these agents have sedative side effects like quetiapine. Some, like risperidone, have hyperprolactinemia. They're all associated with some degree of weight gain and metabolic syndrome compared to antidepressants. And for some medications, you need to consider the risk of QTc prolongation in some patients with risk factors. So again, we have to balance the efficacy of these medications with the additional side effect burden of using more than one medication. So in our simplified algorithm, if you do want to add on a adjunctive medication to the initial antidepressant, then we would recommend one of these 4 medications because of their efficacy and tolerability. And these include aripiprazole, the atypical antipsychotic, bupropion, the noradrenergic antidepressant, mirtazapine, the alpha-1 adrenergic antagonist, and 5-HT2 antagonist antidepressant, and lithium. So one of these would be the recommended adjuncts if you decided to add on a second medication. To give some examples of clinical scenarios for when you would switch versus when you would add on an adjunctive agent, let's look at these 2 scenarios. In the first scenario, we have a patient who's taking sertraline. Their baseline PHQ-9 score is 15, which indicates that they're moderately depressed. Their Sheehan Disability Scale scores were 6, 6, and 6 in each of the work, social, and home domains for a score of 18, which indicates moderate impairment in functioning. They've also shown a minimal response at the end of optimized treatment with sertraline. So their score is still 14, only a difference of 1 point on the PHQ-9. They're also receiving cognitive behavior therapy while they're being treated with medication, and they've noticed some troublesome sexual side effects to the sertraline dose that they're taking. So for these reasons, in terms of having side effects to medications, having moderate impairment, and also getting another treatment, so you might have some time in terms of switching to a different medication, this is a prototypic example of when you would switch from sertraline to another medication, such as venlafaxine XR. In contrast, here's a patient who's also treated with sertraline, but this time their baseline PHQ-9 was 21, indicating that they were severely depressed. Their Sheehan Disability Scale scores are also very high, 27, indicating severe functional impairment. And this time, even though their PHQ-9 score after treatment with sertraline is 14, same as in our previous treatment, our previous scenario, you can see that this is actually a improvement from the baseline score of 21. They've actually had about a 30% improvement in their score, a partial response. And they're also tolerating the medication without side effects. So in this scenario, for this patient with severe impairing depression with a partial response and tolerating the sertraline, this is a situation where we usually recommend adding on an adjunctive agent like aripiprazole. So this just illustrates two scenarios in which the first scenario you would switch, and in the second scenario you would add on. So that completes our discussion of this simplified medication algorithm for antidepressants, starting with selecting an antidepressant, going on to optimizing and increasing the dose, evaluating whether patients have a response or remission to their medication. If they do have a remission, ensuring that they have adequate maintenance treatment on the antidepressant for at least 6 months. And then if they're not in remission, going on to looking at whether you should switch the antidepressant to a different one, or instead add on a medication, an adjunctive treatment like the 4 recommended adjunctive medications. In summary, we've talked about how treatment decisions for depression have to account for both the acute phase of treatment as well as the maintenance phase to prevent relapse. We've discussed how clinical guidelines and algorithms can provide guidance for treatment, but the choice of antidepressant medication depends really on both patient and medication factors that you have to weigh together. And finally, that algorithms and measurement-based care can help identify lack of symptom improvement and symptom remission that can aid you to consider treatment decisions to ensure that patients have an optimal outcome with antidepressant treatment. Thank you very much.